Parents and educators frequently observe a teenager withdrawing, their grades slipping, and their temper flaring. Dismissing this as a typical phase delays life-saving clinical intervention. The clinical reality requires strict attention. In the United States, major depressive disorder reaches a 12-month prevalence near 17% among youth. To see this on a population scale, look at this 10 by 10 grid representing adolescence. 17 dots represent the annual baseline. This expands over time, projecting that 1 in 5 teens will experience a depressive episode by age 18. This high prevalence drives a severe public health metric. For individuals between the ages of 10 and 24, suicide is the second leading cause of death. Waiting for a student to snap out of it allows the disease to progress into a critical state. The delay in treatment often stems from a specific diagnostic hazard. Clinical coordinators try to map the recognized symptoms of adult depression directly onto a teenage population. This creates a blind spot. Adolescents frequently present with what clinicians term the irritability mask, an active state of aggression or annoyance that conceals the traditional markers of a depressive episode. Effectively managing adolescent depression requires shifting away from adult diagnostic heuristics and physically moving the point of care into the K-12 educational infrastructure. When we evaluate teens through an adult lens, we generate false negatives, creating an invisible population that remains beyond the practical reach of traditional clinic-based models. The primary phenomenological divergence between adult and adolescent depression lies in mood expression. In youth, irritability frequently replaces sadness as the dominant prevailing mood state. This comparative matrix illustrates diagnostic differences. Notice how the disease manifests in adults versus teenagers. The expectation of visible sadness is actively replaced by persistent irritability and somatic complaints on the adolescent side. Clinicians look for a secondary cluster of symptoms, lasting at least 2 weeks. They pair that irritability with physical markers, like stomach aches, psychomotor agitation, and a sudden, sharp decline in academic performance. Catching these specific markers requires a deliberate screening approach. The American Academy of Pediatrics recommends a universal screening protocol for all adolescents. Standard adult questionnaires fail here. Providers must deploy the PHQ-A, a patient health questionnaire strictly modified for adolescents, during well-child or school-based evaluations. Without the specific language of the PHQ-A to penetrate the irritability mask, the 17% of teenagers experiencing a depressive episode remain difficult to identify for their parents and primary care doctors. Once an accurate diagnosis is secured, intervention begins. The clinical baseline is established by the landmark Treatment for Adolescents with Depression study, or TADS. This line graph maps the TADS data, evaluating single modality methods versus a combination approach. The first curve maps cognitive behavioral therapy. Used alone, CBT yields a distinct but moderate efficacy slope. The second curve plots FDA-approved SSRIs as a monotherapy. The trial data is conclusive. The combined therapy track breaks away from the rest, establishing a higher efficacy ceiling for moderate to severe cases than either single treatment. Implementing that pharmacological component requires oversight by a licensed psychiatric clinician to safely administer FDA-approved adolescent SSRIs, like fluoxetine or escitalopram. The data supports a clear conclusion. Combined therapy is the established clinical gold standard. Relying entirely on single-modality approaches leaves teenagers undertreated for severe major depressive disorder. Clinical trials operate in controlled environments, but a student with severe depression still has to navigate the friction of their daily, unstructured life. Because the risk of self-harm remains acute, continuous suicide risk assessment is a clinical necessity at every single point of contact. If a teen expresses ideation or talks about not wanting to be here, the immediate action protocol dictates securing an evaluation and connecting directly with the 988 Suicide and Crisis Lifeline. We have the screening tools, the trial data from TADS, yet traditional access bottlenecks prevent vast segments of the adolescent population from ever receiving that combined therapy. The existence of a clinical gold standard is functionally limited if the patient cannot physically, financially, or geographically reach the clinic. Addressing this bottleneck requires a structural bypass. We must decentralize access by moving the point of care directly into the K-12 school systems. This flowchart demonstrates the failure point. Required clinical blocks, therapy, medication oversight, and screening jam up inside the narrow funnel of traditional healthcare, restricted by transportation and waitlists. If we redesign the architecture, we bypass the funnel, plugging those clinical blocks directly into the school infrastructure. Telehealth networks provide the operational framework for this bypass. In Georgia, organizations like MentalSpace School deploy this specific model. Their deployment mechanics remove the physical barriers. They provide same-day teletherapy access, assign dedicated clinical teams to schools, and integrate family counseling, all without requiring the student to leave campus. Embedding the standard of psychiatric care inside the educational infrastructure is a reliable method to eliminate the logistical friction that leaves vulnerable youth untreated. Even with the physical barriers removed, deploying healthcare at the school level faces financial and administrative hurdles. Modern telehealth architectures solve payment friction, as shown on this compliance dashboard. Operating in-network with major payers like Blue Cross Blue Shield, Cigna, and Aetna, and ensuring a $0 out-of-pocket cost for Medicaid patients, care becomes financially viable for families. Bridging educational and clinical systems requires data security to protect a student's medical identity. Providers must maintain a dual compliance framework. The infrastructure has to satisfy healthcare regulations under HIPAA while simultaneously adhering to educational privacy standards under FERPA. This security framework connects directly to state mandates. For districts in Georgia, implementing this infrastructure meets the compliance deadline for House Bill 268, arriving in July 2026. Addressing the adolescent mental health crisis demands action at the systemic level. We must fuse rigorous, data-driven clinical science with frictionless, structurally integrated access.